Good afternoon, everyone. I am happy to be presenting my progress in my PhD thesis, Treatment of Acute Ischemic Stroke. I am Esra Zhubi. I'm a PhD student at the Department of Neurology at Semmelweis University. My vision is to ensure universal access to early stroke treatment and enable patients to lead disability-free lives. And my mission is to advance stroke treatment and prevention through dedicated and innovative research. Here you can see an overview of my two projects which I aim to complete during my PhD. My first project is investigating the predictive role of flare positivity on clinical outcomes after intravenous thrombolysis in known-onset strokes, which we aim to complete through the methodology of systematic review and meta-analysis. In 2019, there were 12 million incident cases of stroke and more than 100 million prevalent cases of stroke. Intravenous thrombolysis is the key treatment of stroke and the prevention of disability. However, IVT has been associated with a risk of symptomatic intracranial hemorrhage and risk of all types of hemorrhagic transformation, which can go up to 34%. Magnetic resonance imaging and fluid attenuated inversion recovery can play a crucial role in predicting clinical outcomes after IVT in stroke patients. So our aim is to evaluate whether flare positivity is associated with worse clinical outcomes after thrombolysis in known-onset stroke. For a context, the no flare signal change is the absence of concomitant lesion in the flare sequence in the MRI, where the lesion is already apparent in the DVI sequence, which is very sensitive to acute ischemic lesions. And the second one shows a concomitant lesion in flare. If the lesions in the flare sequence usually appear after 4.5 hours to 6 hours after the onset of stroke, and they usually tell us about a deeper ischemia, a vasogenic edema due to a disruption of blood-brain barrier. So our clinical question is flare positivity associated with worse clinical outcomes among known-onset stroke patients who undergo IVT within the standard time window. Our population is stroke patients who undergo IVT within the standard time window, and we compare the flare-positive acute ischemic lesions and flare-negative acute ischemic lesions. Our outcomes of interest are hemorrhagic transformation and less favorable 90-day functional outcome. Our hypothesis is that flare positivity is associated with worse clinical outcomes in stroke patients who undergo IVT within the standard time window. Here is our systematic search, which we conducted in 3 databases. And after full text selection, we ended up with 6 studies which we involved in our meta-analysis. Our first outcome is hemorrhagic transformation. This forest plot shows that the odds of having a hemorrhagic transformation is 3 times higher in flare-positive acute ischemic lesion group compared to the flare-negative group of patients. However, the p-value is 0.131, which tells us that we did not reach a mathematical significance, but we consider our findings to be clinically significant and relevant. The second outcome was less favorable 90-day functional outcome, which in the study of Kim and Emreau was considered as a modified Rankin score of 2 and higher, and in Ebinger was considered as a modified Rankin score of higher than 2. This forest plot shows us the odds of having a less favorable functional outcome, which measures the dependency after the stroke, is higher in the flare-positive group compared to flare-negative group. In this analysis, we reached a mathematical significant, and we consider the findings to be clinically significant and relevant. We pulled together the sensitivity and specificity of flare status for hemorrhagic transformation in all of the studies. Even though we did not find a high sensitivity of flare-positive lesions for hemorrhagic transformation, there was a high specificity in the flare-negative lesions, which consequently tells us that if the flare lesion is present, the outcomes are likely to be worse. We have similar results also in the pooled sensitivity and specificity for flare status in less favorable 90-day functional outcome, where the sensitivity is 40% and the specificity is 78.1%. We also pooled the positive predictive value and negative predictive value for the flare positive and flare negative lesions for hemorrhagic transformation. And we can also see here that flare negative lesions have a good negative predictive value compared to positive predictive value. And here for the less favorable 90-day functional outcome, the pooled positive predictive value is 73% and the pooled negative predictive value is 46%. We consider that the strength of our meta-analysis is that it's the first meta-analysis in the topic. It followed a rigorous methodology and it has a high clinical relevance. However, there are many limitations. One is the high inter-study heterogeneity, which we think is due to the effect measures in the involved study. There was a limited number of studies involved, and therefore there were a limited number of patients involved. We also went through the characteristic of each sample in the study, and we found out that all of the studies involved patients of with stroke severity of moderate stroke severity, which based on a NIHSS score of 5 to 15. So therefore, our results might not be, might lack generalizability for the severe strokes. In conclusion, flare positivity is associated with hemorrhagic transformation and less favorable functional outcome in stroke patients who undergo IVT within the standard time window. Our implication for practice is that flare should be incorporated in risk assessment and clinical decision making. It makes the prediction, it improves the prediction, and it's useful in post-thrombolysis management. However, this should not motivate the physicians to exclude otherwise eligible patients for IVT thrombolysis, but this should serve as a predictor for post-thrombolysis treatment, such as it will guide us whether to do the follow-up imaging, when to do the follow-up imaging, and when to start the post-thrombolysis antithrombotic treatment. Implications for research is that further prospective studies are needed to refine and validate the role of flare. We need adjusted analysis to see whether flare acts as a single factor and independent factor or not. We need external validation, and we need certification based on the stroke severity. We have submitted our manuscript in the JAMA Neurology, which is a D1 journal, and this is my second project comparing combined intravenous and endovascular therapy and endovascular therapy thrombectomy alone in acute basilar artery stroke, which we aim to complete through the systematic review and meta-analysis methodology. Posterior circulation strokes are associated with severe neurological impairments and the potential risk of fatality. Basilar artery occlusion, if left untreated, can lead to mortality rates up to 95%. As intravenous thrombolysis is insufficient to yield results in the treatment, endovascular thrombectomy is the most promising treatment. However, recent studies show that combining these two treatments can lead to better clinical outcomes. Our aim is to compare mortality rate and clinical outcomes among acute basilar artery stroke patients who undergo combined therapy versus EVT alone. So our clinical question is, does combined intravenous and endovascular therapy results in better clinical outcomes than endovascular thrombectomy alone among basilar artery stroke patients? Our population is acute basilar stroke patients. The treatments we compare are combined therapy and EVT alone, and our outcomes are 90-day mortality, 90-day good functional outcome, symptomatic intracranial hemorrhage, any type of intracranial hemorrhage, and successful recanalization. Our hypothesis is that the combined therapy is superior to EVT alone in the treatment of basilar artery strokes. If we are to prove our hypothesis, this will serve in the modification of treatment for stroke patients and in the decrease of mortality rate of stroke patients. This is our systematic search, which we conducted in 5 databases. So far, we have ended up with 54 eligible texts. This is our progress. We have completed together with my co-investigator the data extraction, and the data has been sent for data analysis. In summary, these are our projects that we plan to finish by the end of this year. I want to thank you for your attention, and I want to end this presentation with a quote by Miller Fisher that we learn neurology stroke by stroke. Thank you.
Esra, thank you for your presentation. I would like to ask, are you planning to do subgroup analysis based on data from your second project?
Based on the 54 studies that we extracted data from, we plan to do subgroup analysis based on the severity of strokes, so moderate stroke, moderately severe, and severe strokes. We also plan to do a subgroup analysis between studies because we saw that some studies involved only basilar artery occlusion strokes, and the others involved also the intracranial segment of vertebral artery or the occlusion of dominant vertebral artery, which leads to functional basilar artery stroke. And we also want to do a subgroup analysis based on the geographical region, so based on continents Asia, Europe, and US, where all our studies are from.
Thank you.
And also based on the treatment window. We have some studies which treated in the early window. They completed the treatment within 8 hours, whereas the other studies completed the treatment within 24 hours.
I have one question. So regarding your first study, you showed less favorable 90 days outcome in the flare-positive population.
Yes.
Is it like a standalone potential factor for the worse outcome, or should we consider together with the hemorrhagic transformation? So just to simplify, so you have a flare-positive patient and who may not have hemorrhagic transformation in the, let's say, next 14 days, and does it influence the 19 days outcome, or even without the hemorrhagic transformation, the flare positivity could be a standalone negative predictor?
It can be alone. In some studies that we involve, because we have different studies, we have only one common study in both analyses. However, the hemorrhagic transformation in all of the studies involved was evaluated 24 hours after intravenous thrombolysis with imaging of CT of MRI. And the less favorable 90-day functional outcome was evaluated 3 months later. However, this can also, there is also a logic behind it, because the patients who might have had the hemorrhagic transformation subsequently have a less favorable 90-day functional outcome. The KIM study is the one that studied both hemorrhagic transformation and less favorable 90-day functional outcome, but there was no explanation in this matter.
Yeah. Thank you.